Welcome everyone to the Ask the Expert with Dr. Constance Chen and myself. I'm Andrea Smith. We're here today with 30 minutes to talk all things breast reconstruction with you. Dr. Constance Chen is a board-certified plastic surgeon who lives in New York City and specializes in natural tissue breast reconstruction, correcting problems with breast implants, and restoring sensation after mastectomy. Dr. Chen does her best to restore a woman's breast and body so that she looks and feels just as good after mastectomy or lumpectomy as she did before surgery. She and her staff are committed to helping her patients make intelligent, educated, and individualized choices so that they can live long and healthy lives. Dr. Chen is going to start out with a quick presentation overview of breast reconstruction, and then we'll open the chat for you all to send your questions over, and I'll feed them over to Dr. Chen as we go.
Okay. So we thought we would prepare a presentation with some common questions about breast reconstruction. First, there are two main different categories of breast reconstruction. The first is implant reconstruction. What is implant reconstruction? 80% of people in the United States who undergo breast reconstruction use some kind of tissue expander implant reconstruction. You can have saline implants, silicone implants, and they can be placed above the muscle and below the muscle. Here's a patient who is 50 years old. The picture on the left is before her mastectomy, and the picture on the right is after she had a nipple-sparing mastectomy with saline implants. So why do women choose implant reconstruction? On the left is a woman who underwent implant reconstruction by another surgeon. These implants are underneath the muscle. She came to see me. I changed the implants to implants above the muscle. The reason most women choose implant reconstruction is there's only one surgical site. There are no donor site scars from another part of the body, and it's just a simpler procedure all around. The other type of reconstruction, if you don't want to use implants, is natural tissue breast reconstruction. Here's a 42-year-old woman who on the left is before her mastectomy. She had had non-Hodgkin's lymphoma, decided to have mastectomies, prophylactic mastectomies after she developed atypical ductal hyperplasia. And on the right is her after natural tissue breast reconstruction using a DIE flap or DIE flap 7 years later. Natural tissue breast reconstruction can be from different donor sites. Hers was from the abdomen. It can also be from the back, the thighs. You can use muscle, like in the tram or the latissimus dorsi, or you can do flaps without muscle, such as perforator flaps. This was a DIE flap, which did not use muscle. So why do people choose natural tissue breast reconstruction? Well, one reason is that many women with implants in the short term don't have problems, but after 7 years or so, about 50% of women undergo another surgery. 49% of them for capsular contracture, 39% have implant removal, 50% just have another operation for another reason. On the top is someone who had implant reconstruction. She developed painful capsular contracture. And then you can see her after on the right. This is after I took out her breast implants and I did half flaps, profunda artery perforator flaps from the legs to reconstruct her breasts, as well as her nipples. On the bottom left, you can see that this woman here, she had attempted a nipple-sparing mastectomy. This is how she looked when I met her. The left side is wrinkled up, and it's because she developed an E. coli infection. The implant had to be removed. And so I took out her other tissue expander and I replaced her breast tissue with deep inferior epigastric perforator flaps from the belly. On the right, bottom right, is a woman who had a rupture. She's actually the sister of the person on the top. She had an infection on the right as well, and that was removed before I ever met her. This is how she looked when I met her. And then when I saw her, she had a silicone implant rupture on the left. So I took out that implant and reconstructed both breasts using deep inferior epigastric perforator flaps, and also reconstructed her nipple. As you can see, the top three reasons for implant removal are capsular contraction, infection, and rupture. With natural tissue breast reconstruction, you can also restore breast sensation. This woman had a right lumpectomy with radiation. She decided to undergo prophylactic mastectomies of both breasts. I reconstructed her breast with deep flaps from her belly. You can see the scar on the right. You can see the burn on her left breast where the circle is. This happened when she was cooking, and she said that when it splattered her, she could feel it, which she was delighted about, because sensation and pain helps protect you. And so because she knew that she had burned herself, she was able to protect herself. Many women like to have sensation after mastectomies because it feels more normal. It also contributes to their sex life, and it has the protective function. So who is a candidate for natural tissue breast reconstruction? Pretty much anyone who has not had a tummy tuck or a thigh lift or used up their donor sites. This is a very thin woman whose BMI was something like 18. She's a marathon runner. The picture on her left is before her mastectomy. The picture on the right is after bilateral nipple sparing mastectomies and flat breast reconstruction using her legs. Often people will come to me and say that they've been told they don't have enough tissue for natural tissue breast reconstruction. I have found that is almost never true. I've never actually met someone that I could not do natural tissue breast reconstruction on. So there are two good options for breast reconstruction. If you are going to have mastectomy, you can use implants or you can use your own tissue. Here's a woman on the far left is before her mastectomy. The middle picture is after she had tissue expanders at another hospital. I took them out, and on the far right is after she had deep flat breast reconstruction. So she basically had every option. So the choice is yours. I always say that it's your body. You're going to be living in it for your entire life. And so you have to think about what makes the most sense for you. I'm happy to address any questions.
Okay, great. So we can start one question off that I might be able to start off answering, then you can go from there. Someone wrote, I have BRCA2, and I had my prophylactic bilateral mastectomies in 2011 with implants under the muscle. Can I get resensation with implants? Do I need a whole deep process? Do I need to swap out my implants to gain sensation? Thanks so much. So from my perspective, Dr. Chen will talk on the natural tissue part of it. Implants and sensory restoration can happen, but at this time it's being done at immediate mastectomies. So if you want to learn more about how there are surgeons who are doing resensation with implants, you can message me over on the Resensation exhibitor page, and I can help point you to those surgeons through our surgeon locator who are doing that. But Dr. Chen, if you could speak on what someone can do if they're seeking resensation, but they've already had reconstruction.
So if someone has already had reconstruction, but they're seeking resensation, I think the most straightforward way to go about that is to undergo a flap reconstruction. Now, if someone has already had a flap reconstruction, then unfortunately that ship has sailed, because in order to do resensation with a flap, I need to dissect out the nerve during the harvest and elevation of the flap from the donor site. And then the nerve is then connected to a nerve graft, which is connected to a nerve on the chest wall to bring sensation back to the new living breast. So that is the most straightforward way to do resensation if you have already had reconstruction. So if you've had an implant reconstruction, you can have resensation by switching to flap reconstruction. If you have had implant reconstruction and want to stick with implants, I think that, as Andrea said, usually this needs to be done at the time of mastectomy, because the mastectomy surgeon needs to preserve the nerves. So the short answer is yes, you can have resensation if you have already had implant reconstruction or if you have not had any reconstruction. But if you have had flap reconstruction, then you cannot have resensation unless you do a whole new flap, which does not really make sense.
So someone had a question about BMI, someone with a high BMI and breast reconstruction. She didn't specify whether or not she wanted natural tissue or implant-based, but could you touch on BMI and your thoughts on breast reconstruction and optimizing?
Sure, there have been numerous studies that looked at BMI and breast reconstruction, and pretty much all of them say that natural tissue breast reconstruction usually gives a better result for people with high BMI. On the other hand, however, only because sometimes the implants don't look quite right in someone with a higher BMI. The implants may not be big enough, or they don't move and they're just not shaped the right way. That said, when you have a higher BMI, specifically a BMI over 30, you are more prone to infections and wound healing problems. So that is also another issue. So if you have a BMI over 35 or 40, the studies do show that natural tissue reconstruction is generally better, but at the same time, surgery itself may cause more problems due to infection and wound healing issues.
Great. So we have one question that sort of leads into that. I am BRCA1 positive and considering a DEEP, but very concerned regarding recovery in terms of pain and recovery time. Can you speak to your experience with your patients? Anything you ask your patients to do lifestyle-wise prior to surgery?
Sure. So there have been a lot of studies looking at DEEP flap and pain and recovery as well. The ones that are often cited are a very early one in 2000 at MD Anderson, where somebody compared a tram flap, which is a muscle flap, with a DEEP flap, and the intention was to show that there was no difference, but instead they showed that there was half the morphine PCA use, and the person left the hospital one day earlier. A perforator flap breast reconstruction is definitely much less painful than a tram flap breast reconstruction. It's also going to be, usually it's going to be less painful than an under the muscle implant reconstruction as well. And that's because the perforator flaps do not cut out any muscle. In my experience, I never use morphine PCAs on my patients. I've never had to do it. Many of my patients don't even take narcotic pain medication. I give them Tylenol, ibuprofen after surgery, and gabapentin. I do provide them with Valium and oxycodone as well, but most of them don't end up taking it. And I think it's because when you preserve the muscle, when you truly do a perforator flap, it's just less painful for most patients. I do hear sometimes of people having flap surgery with other surgeons where they have had more pain. Sometimes I wonder if they took muscle or if there's something else going on, but in my own hands and in my practice, I have not noticed significant pain.
Great. So how about this one? I had a DTI under the muscle 5 years ago. How do you determine if a patient is a good patient for over the muscle reconstruction? And that also ties into another patient who asked about numbness and tingling in her arms after breast reconstruction mastectomy.
So numbness and tingling under your arms with implants usually is because the implants are under the muscle and the pectoralis muscle has been stretched and it's just constantly uncomfortable. Many people get used to it after a while. Some people don't, and the numbness and tingling bothers them forever. And for some people, they wake up from sleep with that numbness and tingling bothering them. Even people for whom they think it doesn't bother them, I've noticed that when the implants come out from under the muscle, they notice that their pain that they never knew they had has gone away. So how do you determine if a patient is a good candidate for over the muscle? Well, again, this is going to vary from surgeon to surgeon. Not all plastic surgeons do put implants over the muscle. And those who do will often limit it to people who do not smoke or who have not been radiated. I've actually put implants over the muscle in every type of patient without problems. So I don't know that you necessarily do need to limit over the muscle to to any specific patient, I suppose. If the mastectomy skin was very, very damaged from radiation or very, very thin, there might be an issue. But usually if you've had an implant under the muscle for many years, 5 years is plenty of years, then that skin has learned to live with on the blood supply that it has. So it should be fine moving the implant from under the muscle to above the muscle.
Great. Here's one. What are the risks of the different types of reconstruction? Is one safer than the other? So pros and cons of each.
So every type of reconstruction definitely has its pros and cons. I would say the pros of implants are it's often a shorter surgery. There's not another surgical site. Your surgery is limited to the chest area. If it's over the muscle, it's often an outpatient procedure or at most overnight. The cons are over time, people have problems. So according to the implant manufacturers, within 7 years, about 50% people who have implant reconstruction need another surgery, most commonly due to capsular contracture, infection, or rupture. But people also talk about breast implant illness and autoimmune diseases. And of course, there's been a lot of media attention paid to anaplastic large cell lymphoma, and now people are talking about squamous cell carcinoma and whatnot. Natural tissue breast reconstruction, the big con is it's a much more complex, it's a larger surgery. You have more surgical sites, so it's not only your chest that's being operated on, but also a donor site, such as the abdomen or the legs or some other place. You have more drains. For some people, you're going to be in the hospital for longer. Some of my patients do go home on day 2, but usually they go home on day 3, whereas in above the muscle tissue expander implant reconstruction goes home the same day or the next day. The pro of natural tissue breast reconstruction is that it's permanent. It eventually integrates with your own body. It's alive. If you develop an infection it's like developing an infection in your native breast or in any other part of the body, you take antibiotics and that's it. Whereas if you develop an infection in the implant, then you will, you probably need to have it removed. And you can, that's really the only surgical emergency with implants. So the safety risks of each are different. And I would say implants are a nice shorter term solution. They do have more problems in the long term. And flaps are much harder in the short term, but there have been many studies that show that the patient satisfaction tends to be higher in the long term.
And I can't remember if you touched on this, pros and cons under versus over.
I don't know so the pros of under, I suppose, is you have one more layer of tissue. And that's why people have traditionally placed implants underneath the muscle. There's another layer of tissue that people used to worry about the implant eroding through the skin after mastectomy, particularly if you have radiation. Whereas when it's over the muscle, it's much more comfortable. It's anatomically correct. In people with compromised mastectomy skin, you need to be more cautious.
Great. And then what about pros and cons on aesthetic flat closure? That's definitely a topic of breast reconstruction that a lot of people are interested in nowadays.
Sure. Yeah, so aesthetic flat closure, I think, is great for many people. It's basically not having reconstruction and just going flat, so to speak. It's the quickest recovery. You should be able to go home the same day as your mastectomy. I would say if you're going to go flat, this is not exactly aesthetic flat closure. I would strongly recommend undergoing a nipple-sparing mastectomy and allowing your skin to contract, even if it looks weird up front, because oftentimes you will look fine at the end of the day. I think one thing that people talk about with aesthetic flat closure is resecting excess skin up front so it looks nice and tidy. The thing I don't like about that is you're definitely burning bridges. You can't get that skin back. And unfortunately, I have seen people who have gone flat who have changed their minds later on. I think if the people who go flat, have a nipple-sparing mastectomy, decide they look kind of normal, even if they had planned to get some kind of reconstruction, may decide they don't want reconstruction. So there's different ways of going about it. I always hesitate to do something where it's just irreversible.
Sure. So let's talk about scars. Where are the scars typically placed, or what are the options for nipple sparing mastectomy? And then also with the different types of flaps that you do.
Sure. So for nipple sparing mastectomy, I actually wrote a paper on this. There are lots of different types of incision. For people with smaller breasts, first of all, it's going to depend on your breast surgeon and how talented your breast surgeon is, whether A, they can even do a nipple sparing mastectomy, and B, where they can place the scars. But the where the scars are placed, a lot of times it's going to depend on the shape of your breast. If you have a smaller breast, then usually the scar is going to go in the inframammary fold. That's also a great place for a scar if you have a slightly more ptotic breast, meaning a droopy breast, because then the scar is very hidden. If you have a very droopy breast, i.e. your nipple is pointing straight down, then you'll probably need a vertical incision, which is similar to where an incision would be placed for breast lift. And at the second stage, you may actually need a breast lift. You can also place the scar on the side of the breast. Some people feel like that sort of edits out the scar altogether. You can also do periareolar scars. There's lots of different types of scars that you can do for nipple sparing mastectomy. A lot of it is going to depend on the skill of your breast surgeon and how much your plastic surgeon communicates with your breast surgeon. With flaps,
before we do that, can we talk about women who aren't candidates for nipple sparing mastectomy and optimizing their aesthetic outcome with scars as well?
Sure. So someone who's not a candidate for nipple sparing mastectomy, I would advocate for a periareolar scar. So the areola is the dark circle on your breast. And you can cut that dark circle out, and you can even make a vertical line underneath it, like a breast reduction scar, and then purse string that scar so that you preserve the dome of your breast. Now, this may not be something that your breast surgeon is familiar with. They may insist on just doing the straight line scar across your chest. That is the standard mastectomy scar. The problem with that scar is it flattens the breast, and unfortunately, you can't regain the shape of a normal breast after that. It just becomes a flattened breast. So, you can try to talk to your breast surgeon about doing a periareolar scar if you are not a candidate for nipple sparing mastectomy. It will probably depend on, again, the skill of your surgeon and how open-minded they are, if they're willing to do something like that or not. With regard to the scars for the flaps, for the deep flap or the tram flap, it's the scars on the lower abdomen, similar to a tummy tuck. For my second choice flap is the pat flap, which is from the upper inner thighs. The scar from that is in the buttock crease. It's hard to see, which is why I like it. It's the same scar as in the thigh lift. Many surgeons also do something called the latissimus dorsi, which I actually don't do because, again, it's a muscle flap, and I don't believe in sacrificing muscle for breast reconstruction. But what I do is a thoracodorsal artery perforator flap, which is like a latissimus dorsi flap, except for you leave the muscle alone. And that scar is in the back in the bra line.
Great. And then how about scar management after surgery? What do you recommend?
So I would recommend, there are lots of things to do. One thing that I do a lot with my patients is something called Provena scar management system. It's a expensive and complicated dressing that you put over the incision to take all the tension off the wound and reduce the risk of infection. If you've ever heard of a wound vac, it's like that. You're hooked up to a contraption that has negative pressure on the scar, and it really minimizes the scar and any. It makes it almost impossible to have an infection postoperatively. Once the scars have completely healed, meaning that there are no scabs on your scars anymore, then you can start doing scar massage. Another thing you can do is silicone strips. You can put silicone strips on your scars as well.
And then I would add about sunblock as well, and sun exposure that first 6 months or so really can pigment a scar. So really protecting your new scars as long as possible from the sun would really help a lot as well.
Or your old scars, just forever.
Yes.
The scar can really become pigmented and almost turn into a tattoo if you expose them to sunlight.
Someone had a question about scars. If she's decided to swap out from implants to tissue, how big are the scars on the legs, for example?
So if you're going to switch from implants to tissues. So
Yeah,
it
like if you
depends
wanted
on
to
what
have a
you're,
calf flap or a tug, what kind of
Right.
scar are we looking at?
So it depends on what kind of scar you have right now. If you have a nipple square mastectomy and you have an
Oh,
inflammatory.
I'm sorry, at the donor site.
Oh, so again, the scars on the donor site for a D flap are like a tummy tuck scar, so it's from hip to hip. And for the pat flap, it's in the groin crease. It's actually quite hidden, it's hard to see. You pretty much have to be spread eagle for someone to see that scar.
Okay. How do you monitor breast tissue after deep flap is transferred for the blood supply?
So after you have a deep flap, usually you've already had a mastectomy. So hopefully you don't have any breast tissue left. So most breast surgeons do physical exam afterward, because even though the deep flap might look like a regular breast, and it is hard to tell sometimes that it's not a regular breast, it's actually not breast tissue, it's abdominal tissue. So your breast may look and feel exactly like a normal breast, but there are no hormonal receptors, and you're not going to be able to breastfeed or anything like that because it's abdominal tissue filling up the breast skin.
Great. Someone has a question on preventive mastectomies and the relationship between the breast surgeon and the reconstructive surgeon. If you're having a preventive mastectomy and a breast surgeon is working with the plastic surgeon who performed the reconstruction, can the results be influenced significantly by the work of the breast surgeon's mastectomy, or is that pretty much the same most of the time?
It is definitely influenced by the breast surgeon, in my opinion. Number one, if the breast surgeon knows how to do a nipple sparing mastectomy, that's going to be a huge factor. People at Force assume that all breast surgeons do nipple sparing mastectomy because they hear all about nipple sparing mastectomy. But the reality is most breast surgeons don't do nipple sparing mastectomy. And you may go to a breast surgeon who tells you you're not a candidate, when the reality is you may be a perfect candidate, but she just doesn't do them, or he doesn't do them. If you're undergoing prophylactic mastectomy, then I can't think of a single reason not to have nipple sparing mastectomy. You don't even have disease in your breast, as far as we know. There have been lots and lots of studies that show that people with a genetic tendency to breast cancer who have nipple sparing mastectomy reduce their risk to, single digits, much better than the general population. So while nobody can ever reduce their risk to zero, as long as they're alive, you're getting as close as you can if you have prophylactic mastectomies. So can your results be improved by a good breast surgeon? Absolutely. I'm very picky about what breast surgeons I work with. I only work with people who do nipple sparing mastectomies. And people who do nipple sparing mastectomies can be more talented and less talented. It is definitely not one size fits all. Some are more thorough in their mastectomies in terms of removing all of their breast tissue. So they have lower risks of recurrence and things like that. Some just do a nicer job with their incisions, or they don't lose skin, or they don't lose nipples. And so a lot does depend on the skill of the breast surgeon as well. A good breast surgeon definitely makes my job a lot easier, because the outer covering of the breast is intact.
And that kind of falls into another question about, the order of selection when you're trying to choose a team. And sometimes when you're seeking a prophylactic mastectomy, you may want to find your reconstructive surgeon first and then work backwards. Just a thought on options for that. Someone had a question. What questions should a patient ask a breast surgeon, or how should they go about choosing a great breast surgeon? I sort of just answered that, but do you have any other thoughts on good questions to ask a breast surgeon?
Well, if I was looking for a breast surgeon, I think the first thing I would do is make sure they are skilled at doing nipple sparing mastectomy. I would, do all the normal things of looking at their background and their reputation in the community and whatnot, how their rates of recurrence, things like that. But for me, if I were a lay person looking for a breast surgeon, I think, frankly, the most important thing to me would be whether or not they do a nipple sparing mastectomy. Because someone who does a good nipple sparing mastectomy is going to be a highly trained and skilled breast surgeon. So almost by definition, oncologically, they're going to be fine, because someone is not going to be doing a nipple sparing mastectomy if they usually if they're not fellowship trained and they aren't quite advanced in their surgical skills.
Sure. And we only have a few more minutes. I definitely want to hit on insurance. Does insurance typically cover out-of-state patients? I'm BRCA2 and had mastectomy with implants, but would like to change to natural tissue.
That's probably a question for you.
Well, so breast reconstruction in general is a covered benefit by your insurance, and state borders typically doesn't restrict your ability to get breast reconstruction. And if you've had reconstruction and you want to convert to something else, your insurance can't tell you no. There's a handful that may give you a hard time, or you may have state restrictions if you're on an HMO, but it's worth exploring. And, I think that you should advocate for yourself and do what you can to, get out there and get the doctor that you want and feel that you deserve, you should have. So I think we're out of time.
Okay. I was going to say there is a federal law protecting a woman's right to choose their surgeon and their medical care for breast reconstruction. And then there are numerous state laws too that back that up even more. Basically, any insurance company that covers mastectomy is required to cover breast reconstruction as well as their type of reconstruction that you want.
Perfect. So with that, we're going to leave it here. 30 minutes goes by so fast. We had so much fun, Dr. Chen. It's always fun chatting with you about breast reconstruction. If you want to speak to Dr. Chen more about breast reconstruction, you can catch her live all day today and tomorrow in her Zoom room through the exhibitor hall. And you can also see her in the Q&A panel. I believe that's later this afternoon too. And I'm available through Resensation. If you have Resensation questions, feel free to send a message my way. Thanks so much, everyone. We had a great time and happy conferencing.
It was nice to see you all.